Hi, I'm Eric Potashnik from the Watson Institute, and I'm the editor of the Journal of Health Politics, Policy, and Law. It's my pleasure today to introduce Harold Pollack. Harold is the Helen Ross Professor at the University of Chicago School of Social Service Administration, and he will be talking about is Medicaid the future of bipartisan health policy in the United States. Thank you so much for joining us today.
Thanks, Eric, so much. And I must say, this is an intimidatingly wonderful looking facility. Maybe we should go back to the smaller room so I'm less intimidated. We're in the middle of a conference on health policy in this moment around AHCA, and I do find myself being the situational optimist, although maybe I'm a little bit more of a long-run optimist than an optimist about what's going to happen to the particular AHCA and Congress. But I do think that one of the remarkable aspects of the debate since the election is the political resilience of Medicaid and in many ways what you might call the strength of the non-submerged welfare state in American health policy. And I think when I try to take a longer view, I think that over the long run, we are really setting the stage for an expanded public role in insurance, and oddly enough, this AHCA debate may ratify a public consensus around a larger public role. So I should say that I come at Medicaid with a profusion of roles, probably too many roles, and I have kind of a dog's breakfast of a talk about some of those roles that you're about to see. I figure we've had a bunch of papers delivered, so a more sprawling, random stream of consciousness is appropriate for lunch. One thing is I'm a political advocate. I was one of the worker bees who worked on ACA, and for all of its flaws, I'm certainly very proud of the best accomplishments in ACA. I'm also a health policy researcher who's published on Medicaid, and I'll talk about some of the work that we've done. And I'm also a Medicaid consumer, and my wife and I have been guardians of her brother Vincent for almost 15 years now, and he receives medical care and services financed by Medicaid. A lot of people actually around this table have helped me in various ways in that effort, including with Glenn Lowry, by the way, is a good friend and mentor who's joined us for lunch. One of the striking things about the current AHCA debate that we didn't talk about so much today is how the families like ours who rely on Medicaid are a potentially explosive political force. And I think Republicans are really risking a firestorm from people like my wife that will make the backlash over the Medicare catastrophic coverage seem somewhat tame by comparison. I don't know if anybody's been watching the videos that have been shown. For example, on CNN, there was a woman whose little Facebook video was just shown on CNN the other day, where she's from North Carolina, and she went to Representative McHenry's office, and she said, "I'm here because last night Representative McHenry voted for my baby to die." And there's a lot of people doing that, and this is a permanent constituency. And yet one of the liabilities that President Obama ran into when ACA was passed was that he got to own a lot of the infirmities of the private insurance system. Lots of people on the exchanges, lots of people in many ways hoped that their health insurance would get better, and they discovered that it basically continued on the same trend it had been on before, but now this ACA thing was supposed to repair that, and it didn't. And that became part of the backlash to ACA. Well, every mom who's trying to get a wheelchair for her child on Medicaid is going to blame AHCA if she can't get it. And since AHCA includes a 25% cut in Medicaid by 2026, that argument will have a considerable amount of validity to it. And I think that if you block grant Medicaid, there's just the reality that the aged and the disabled are where the money is in Medicaid. states will have to do things towards those components of Medicaid that will be very politically damaging. I should also say in some of my other roles, I'm a midlife crisis journalist and write a lot about Medicaid, and very often the human faces of Medicaid recipients are the things that generate the most striking response across the political spectrum to the things that I do and the things that other people do. And I'll mention one final role that I do, and I'll start by telling you some experiences that we've had. Most of my urban public health research is doing intervention trials with people who are at the intersection of healthcare, severe vulnerability, and the criminal justice system. So I'm the co-director of something called the University of Chicago Health Lab, and we do randomized trials of violence intervention and services to help people who are severely vulnerable. And I do a lot of work in the Cook County Jail. And also with people who are arrested but who need health interventions that the police don't want to deal with. They want to find a social service or medical provider to deal with. I would say 80% of the arrestees and detainees in our randomized trials are insured through ACA's Medicaid expansion. 5 years ago, roughly the same percentage of people would have been uninsured. It's actually fairly remarkable. Cook County Jail has done an amazing job of enrolling everybody in Medicaid who's eligible. And they do that, by the way, on the front end. The trick in doing this is to enroll people in Medicaid when they arrive, which is quite difficult because they arrive in whatever circumstance they arrive at the jail. But it takes a while to do the bureaucracy. If you don't enroll them when they arrive, it's very hard to enroll them when they leave because there's just no time. And correctional populations across the country in the expansion states are actually a surprisingly large chunk of the expansion population. If you count parole and probation, it's a large population, and people with addiction disorders who are not currently in the criminal justice population but could be are also a big chunk. And what's striking is that Republicans around the country have not Willie Hortonized this aspect of ACA. A lot of us, this was pretty obvious pretty quickly. Who is it that's going to really be the core of the ACA Medicaid expansion? Young guys, low income, not eligible categorically for Medicaid in any other way, and who need health coverage. If you start thinking about that in a place like Chicago, you start realizing Cook County Jail is going to be a major place for that. And it's really striking how that's been a dog that has not barked in terms of the toxic politics around ACA. Now, I should say that the states that are purple that have expanded, the majority of their poor populations are white. And a lot of the folks that are leaving the Ohio correctional whatever are white. And I think if Alabama expanded, if Texas expanded, politics might conceivably be different. But it's really striking. So just 2 weeks from today, my colleague David Meltzer and I are actually going to be present at the opening of something called the Supportive Release Center. And it's a collaborative effort with the jail and with two nonprofit organizations, a Heartland Health Outreach and a substance abuse treatment provider called TASK. And what we're doing, here's the problem. We're trying to help borderline homeless detainees who show up with behavioral health disorders. And maybe they arrived to the jail, maybe they've been shoplifting, maybe they went to a restaurant and then left without paying, maybe they were cursing people in the street. They're the urban rabble of Chicago. And so they arrive at the jail and they leave pretty quickly, usually, once their paperwork is done. The jail's a pretty depressing place. You basically want to get the hell out of there as soon as your paperwork is done. Could be 10:30 at night. And so they leave, and if they have a mental health problem, they might get a prescription for some medication. Someone might make them an appointment at Stroger Hospital to come in the next day. But the reality is that they go off into the night and you really have no idea what's going to happen to that man and woman. They're 26th in California, which is way on the west side of Chicago. They often walk home. You know, they'll get a little bus ticket, but there's a couple of buses to get anywhere, and you just don't know what's happened, and whatever their social connections are with their housing, are they living with someone, whatever, the thing that brought them into the jail might well be the thing that disrupts their life situation. And in that critical moment, when they're at maximum personal vulnerability, they're crossing between administrative systems where they often slip between our fingers and no one is watching what's going to happen to them. So from a public health point of view, this is a very serious problem. And so what we're trying to do is we're building some trailers on the, this is going to come back to Medicaid, by the way. You may wonder, where is the word Medicaid? It's coming. So we are building some trailers just off the grounds of the Cook County Jail. And people can come there, and there's a randomized trial to evaluate this. They can come there, they get 3 hots and a cot, and they get a change of clothes, and they can get a drive the next morning to their appointment, wherever they need to go. And some of them will get longer term follow-up with case management. I should say that this whole thing, by the seed money, is provided by the Pritzkers, and this thing costs $168 a night. So we figure it's pretty competitive with the Hyatt downtown. And we specialize in these lean, scalable, simple interventions that we're trying to do because we're going to have to do them for a lot of people if they're effective. And here's where Medicaid comes in. This whole thing is made possible and will be made sustainable because the services that are provided, both in this and then once they leave, will be, there's a CPT code in Medicaid for it. That's the whole, that's basically the whole ballgame. And that either it's direct reimbursement or because Medicaid managed care plans who own these people, their healthcare expenditures, they want to see these people, their needs addressed in this critical moment. Now we have a second trial going with nonviolent drug users and drug sellers who were swept up when the Chicago Police Department brings down open-air drug markets. And you have this problem that they'll make a social network map of maybe 150 people in a drug or selling organization, and they'll arrest them all on a given day because there's a spot usually like right off of the highway or something like that. And they'll say, well, there's 40 guys that we just don't want. They're the hired hands who are standing out in the street, usually they'll say, like, you sell 10 dime bags and we'll let you keep 1 or 2 for yourself. And a lot of these people, they're not, they don't have a history of violent offenses. It's rather poignant. There's one guy, we have a consent process, and it's a surprising number of them can't actually go through my consent process because they're middle-aged people and they don't have their reading glasses with them. So I hand them the consent form and they can't read it. Yes, go ahead.
Can I ask you a question about this?
Sure.
Why the violent, non-violent distinction? What work does that do?
Well, because what we're going to do, the people that are in the intervention are not going to be arrested at all. They're going to be sent to a social service provider, and the Chicago Police Department does not want to do that if there's someone where they feel is a public safety risk. So if there's a history, so if there's gun offenses, if there's recent felonies that the police department regards as a public safety risk, they actually want to arrest the guy. But if it's just, there's one, but a lot of these people, that's just not their story. There's one guy that I was talking to, this is his part-time job, that he spends the rest of his time helping his dad take care of his mom who has dementia. And he basically comes down into the street and earns extra money when he can selling drugs. And all of these people are all insured through the ACA Medicaid expansion, which is paying for all this stuff. And what's really striking, Chicago's version of the ACA Medicaid expansion is imperfect and administratively screwed up, as Illinois is very creative in doing. Many, many problems with it. But it's become the platform that we're using to create an integrated public health system for severely vulnerable populations. And for instance, 1/3 of the people in Illinois living with HIV are Illinois ACA Medicaid expansion people. It is phenomenal. There's a lot of interest in combining housing services for people with severe problems, using Medicaid to pay for services to deal with the social determinants of health. Now, sadly, had Hillary Clinton won in November, right now we'd be having a whole conversation about how to do this work really well. And instead, we're actually having the work, how do we defend the existing structure of Medicaid, and we can't do the real work. We have meetings like this where we're talking about how do we keep alive this infrastructure. But it's really striking how much of this is going on. There's this debate that sometimes goes on, does Medicaid help people? Is it better to be uninsured or to be on Medicaid? And there's a whole health services debate based on the Oregon health insurance experiment. Is there an effect on mortality of Medicaid and so on? For those of us that work in public health on the front lines, this is kind of a stupid debate. It is, there's a lot of interesting health services research and epidemiological questions to be answered, but we see every day that it's transforming people's lives. And just one example is our gunshot victims. So it turns out before ACA, most people in Chicago and Detroit and other places who were shot tended to be uninsured. That's just who gets shot in America. And so what's that?
That's why I'm laughing.
Did I say something?
No, that's just perfectly reasonable.
So one of the things that we had in Chicago was a humiliating number of people walking around with colostomy bags because they couldn't find a surgeon to do the elective surgery to close up the abdominal gunshot wound. And we have people walking around with helmets because they had missing pieces of skull, and they couldn't get into the major medical centers to have the repairs done that now are done routinely, financed by Medicaid. And for the severely vulnerable populations that I work with, there is just it is transformational in an everyday way, despite the many ways that it's screwed up and the many ways it needs to be made better, largely through reimbursement. And here's what's really striking about it, is that everyone across the political spectrum on the ground sees this and understands this. And the conversations we were having about the radicalization of the House Democrats, for example, of the House Republicans, rather, that we were talking about this morning, and the asymmetric polarization, that's true in Congress, and it's true in parts of the country, but it's not true in many other places. And with my colleagues, Colleen Grogan, Cliff Bursamira, Christine Andrews, and Amanda Abraham, our study team on the National Drug Abuse Systems Survey, we've been calling addiction professionals around the country, policymakers, state government officials, people who run clinics, drug treatment clinics, and we're talking to them about how they use Medicaid to deal with services. And what's really striking is we don't see the health policy nihilism that Jim mentioned earlier when we talk to people. So you call up someone from Ohio or Kentucky or other Republican states that have done the Medicaid expansion, and you call up a state official and you say, so tell me about your addiction and Medicaid. And what they say is, well, we have the ASAM continuum of care, and we have these people that we think should be in residential care, but the IMD exclusion in Medicaid won't actually pay for those people under our existing Medicaid structure. So we're getting an 1115B waiver from CMS to try to figure out how we can align our Medicaid reimbursement with what our with what our treatment people want to be doing. And it's basically conversations about the work. It's not, and in fact, when we say, well, what about there was an election in November? And they'll say things like, well, we've been told to not do anything different after the election. That we should proceed as if everything we're doing can be continued. And it's by the governors of their states and the top officials in their states. And it's really striking. And they're getting a lot of these waivers. Now, I don't agree with a lot of these waivers. You talk to people in Indiana, there's a lot about their Medicaid program that I don't like. That's called, you got to go out and win elections if you want to get the waivers that you like. at the state level. But it's not the story of partisan polarization does not automatically filter through across the states at all. And the work is often quietly bipartisan on Medicaid. And there's a lot of bipartisan negotiation and bargaining between the Obama administration and the states. In fact, even the states that didn't expand Medicaid. If you're talking Medicaid expansion, these governors can't do much. But if you say, let's talk about, say, money follows the person, or the junk DNA of ACA that's in Medicaid that provides services for people with disabilities, you'll discover there's a ton of conversation going on. They want the money. And then they also, if it's off of the front page, it's a different kind of politics. It's a more interest group politics. It's a more pragmatic politics. And people in the state legislature, everybody's got a cousin who is intellectually disabled, or they are a recovering alcoholic. You know, there's a lot of human connection to the Medicaid population that tempers the otherwise unworthy politics that goes on around Medicaid, more than we might think. And so there is a governing wing of the Republican Party. It just is not running the House of Representatives. And you know, that is, and the states and the federal government have been searching for a politically dignified path to do a lot of this negotiation. And it's really quite striking. And in fact, many Republican governors were looking for public fights with the Obama administration to give them some breathing room to do this kind of negotiation. You know, you want to have a big fight. So, for instance, Michigan actually had their Medicaid waiver. In a lot of ways, they were desperately trying to find something that Obama would object to, so that they could do their Medicaid expansion with some political cover. And you know, I think that, and it was just a striking thing. And now I must say, the Washington conversation that I have with policymakers around Medicaid is much more depressing. It is. I was at an off-the-record dinner with Democratic and Republican Congress people a couple months ago, and no one was very happy on either side. The Republicans were actually smart and nice people, but they were. I really enjoyed meeting them. They were not health policy people. Their passion was not health policy. They didn't know a lot about health policy particularly. They knew a lot about other policy areas that were their passion. But they basically said, we have pledged to do this thing in ACA. We kind of have to do it. We know it's going to be bad, and we know it's going to be unpopular, but we're kind of stuck. And in fact, what was striking was when they talked about President Trump, they had the same views of President Trump that most of us in this room would have. And in the 3 hours of conversation about policy detail, the White House never came up. You know, usually a conversation like this, you're talking, and people would say, well, this issue, the White House kind of has a view that is, they don't want to push this issue. Their priorities are over here. There was no ability of the White House to sort of exercise any kind of direction or solving collective action problems that the legislators have. It was clear that the only thing that people would say about the president was that they were upset that he was unifying the Democratic opposition. In fact, the most conservative people in the room were saying, I wish he weren't so polarizing, because now no one wants to work with me on the Democratic side. And it was sort of a striking conversation. And you compare the conversation I was having with these representatives with the letters that Republican governors were sending to Congress about AHCA. And so 4 governors, Governor Kasich and also governors from Michigan, Nevada, and Arkansas, wrote a letter to Congress that was very critical of AHCA. And, you know, and what was remarkable about this letter, you know, once you got past the boilerplate and some of the policy positions, was that it was very tactile and it was very operational in a way that none of the Republicans I talked to in Washington were being. So they said, you know, we don't want you to do per capita caps. If you do the per capita caps, you're using the wrong medical care price inflators to do that. And we think that it's not going to keep up with the costs. And they talked like people who knew they were going to live with whatever was decided. You know, the Republicans really were, how do I get over this? The Republicans I talked to in DC were much more, how do we get over this hurdle? And these governors were much more like, what's actually going to happen? because either that rural hospital is going to close or it's not. And we're going to own that. And even if now there's no political penalty for signing AHCA, there will be to us. And 15 Republican governors expressed concern about cutting Medicaid. Governor Rauner has been very supportive of the work that we do, and just in their on-the-ground work, many people around the country that we've talked to, when you say, what about the politics of Medicaid, they will specifically talk about the opioid epidemic. One of the really striking things about Medicaid politics is that a lot of people thought when ACA was passed that the addiction and mental health components of ACA would be a political liability because these are the unworthy poor that we're helping. It has actually been the opposite. In the Senate Finance Committee, all those provisions passed unanimously with Republican support. George W. Bush was a strong supporter of parity. Pretty much the only major Republican political figure that opposed this stuff was Tom Price, who's now unfortunately Secretary of Health and Human Services, who also opposed George W. Bush's global public health initiatives, among other things. But a lot of, when we talk to people around the country, they were saying, we're debating the Medicaid expansion. It's actually a heavy political lift. One of the ways I explain to my constituents why I'm doing Obamacare is I say, we've got this horrible opioid epidemic, and we've got to find resources to deal with it, and this is going to help us do that. And that was a major political factor in the states that were majority white, low-income populations where they're experiencing the opioid epidemic quite fiercely. And it's not that the governors don't care about or understand the partisan politics around ACA, but they see the way Medicaid expansion serves their own political and governance purposes, and they see that doing away with Medicaid expansion is going to cause them a huge problem, and that they are the political home address for a lot of the defects in this legislation. And they are very aware of that. So Governor Kasich is the most upfront, where he just says, we don't want to lose coverage for 700,000 people in our state, but there's many other Republican governors who are a forceful restraint to some degree. Now, there's a limit to their sense of ownership. And this gets to why ironically, this gets to why I think that Medicaid has more of a future than some other pieces of ACA, which is that none of these governors and none of these state officials that we talk to have any particular sense of ownership or accountability over ACA's marketplaces at all. If we say, what's going on with mental health and addiction parity in your state, on your marketplace for people purchasing private insurance, they have no idea. They don't know, and they're not that interested to find out. If ideological compromise were the central factor in American politics, then you would expect the reverse. You would expect that the marketplaces, as this market-oriented proposal with a lot of Republican DNA, would be the thing that Republican politicians around the country would gravitate to and want to make work and want to make their own, want to have a state marketplace and do their own thing. But of course, that's not what's happening, and it's because the ideological foundations of public policy are just not what brings about bipartisan support. And I was reminded, Eric Potashnik reminded me over Twitter about Francis Lee's terrific book Beyond Ideology, which I think is a useful lens to understand some aspects of this, although I defer to basically everybody else here except Glenn about the political science involved in it. Glenn probably has some hidden skills that I don't know about. But only one politician is identified with these marketplaces, and for that reason, Republicans united against them, and he's not president anymore. And so the marketplaces are fragile. They're institutionally complex, they're financially constrained, and they're in need of continual care and feeding from both Congress and the president. Now, those factors alone, you could deal with everything I just said. If you describe the history of Medicare Advantage, it had a lot of those same features. But if the marketplaces are also caught in a polarized partisan fight, it's not clear to me that these are stable. And one of the striking things about this is the human experience on these marketplaces is pretty poor for people who are above about 250% of the poverty line. And so, they're really just not working very well. And they could be fixed, but it's not clear that Republicans believe that it's smart for them to fix that. And they believe that the Obama administration will be blamed if the marketplaces do poorly. Speaker Ryan likes to say Obamacare is in a death spiral, and President Trump said the best thing we can do politically speaking is to let Obamacare explode. I think the losers are Nancy Pelosi and Charles Schumer because they own Obamacare. I'm actually not convinced that their political calculation is right, partly because he's just saying it. There's an aspect where if you're saying I'm going to sabotage this thing, but it's going to be these other people's fault, that's not the smartest approach. I'm sort of reminded, there's that, they had people talk about the collapse and replace. And so, anybody remember the movie Blazing Saddles, where Cleavon Little pulls out a gun and he holds it up to his own head? And that is basically, there's an analogy there.
Can I make a point?
Yes.
In 1995, there was going to be a veto battle about shutting down the government. And the Republicans kept saying, we're going to shut down the government. We're going to shut down the government. We're going to shut down the government. Guess who got blamed when Clinton vetoed and the government got shut down?
Yeah, and so, but so there's this question, they may be right and they may be wrong about the ultimate blame for this. But what I really, and by the way, we're already seeing with the 2018 rates that insurers are tacking on a premium because of the CSR issue and because of the mandate issue that the Trump administration has made insurance more expensive. But the long-term trajectory is really what I think Republicans want to be thinking about. Because, they have this bill that the AHCA, which is roughly polling with Madoff, if you sort of look at many of its features. They may still pass it. The debate over AHCA has really ratified the national consensus that every American is entitled to affordable and decent health coverage. I mean, that's really, even the things that the Republicans are saying that are not true about ACA are saying we are going to provide every American with. And now, of course, there's a lot of gymnastics around the word access, but they are ratifying a consent. They are not saying we think it's actually okay for 24 million more Americans to be uninsured. I mean, some people are, but I think that is not the public posture they're taking. They're basically saying our bill is going to make things better for people. And if the marketplaces can't deliver on that promise, and if the Republican bill doesn't deliver on that promise, what comes next? I think the marketplaces won't just be scrapped. They'll be replaced by something. And when I think about Paul Starr's midlife Medicare, for example, and the kinds of proposals that people are talking about, they're all for an expanded public role that is actually quite popular even among a lot of Trump voters. And if you look at the economistu.gov poll, for example, 60% of Americans, including 46% of Republicans and 43% of self-identified conservatives, somewhat or strongly favor expanding Medicare to provide health insurance to every American. There's just little public support for any proposal that combines reduced insurance coverage with tax cuts for the most affluent people, and that's what they're doing. And so Democrats are out of power. It's a very paradoxical situation where I've never seen something where one party holds more levers across all three levels of the federal government and has run for the past 7 years, pledged to do exactly what they're trying to do, and has so little public standing to do it in this moment. And I think this is a very generative moment where the most likely outcome, maybe not this year, maybe not next year, is for a really expanded public role. Because in some ways the failure of the marketplaces and their abandonment by the constituencies that might have defended them has just delegitimated the Republican path that would get us towards more universal coverage. And I think that in contrast to that, I think the number of constituencies, patient groups, provider groups, others that are involved with Medicaid and that basically see it working pretty well and that have joined it and have created a sense of collective ownership because these Republican governors have spent 7 years building these Medicaid systems. that is going to generate real momentum. And it is ironic that bipartisanship is coming from a public insurance program that was specifically stigmatized as welfare, but that turns out to solve an awful lot of problems for transactional politicians that a more ideologically moderate vision is not. And so there's a pony here someplace in this current political predicament that we are in. And I think Republicans would be very wise to consider how they're going to use their brief window of power they have right now, because whether Obamacare is in a death spiral or not, the Republicans might find themselves in one if they overstep where they are. And 2018 and 2020 are really close. So I'm feeling good. What's that? Not close enough. So I'm going to stop here, but that's my situational optimism for today. I saw a lot of unhappy looking faces as I was doing this. I was looking happy.
I'm feeling a lot better than I did before lunch.
Right. Never has a lunch been so nutritious and so edifying.
Thank you.
So, Harold, could you talk a little bit about, we heard before lunch, about how no governor would step up in terms of the possibility of suing to preserve individual rights under Medicaid. You've told a very different story. And your story has a lot of Republican governors believing in Medicaid. Could you help us sort out how to weigh these two stories, Sarah's story and your story?
Well, there's I don't know enough about Sarah's story to tell it in a granular way. I agree that I think governors are very dependent on the federal government, and especially when the Trump administration has one strategic asset, which is their vindictiveness and discretionary control over billions and billions of dollars is going to constrain what some of the states are going to do. And New York's, there are a lot of states where their Medicaid programs need federal help, and Seema Verma's made it quite clear that she's going to be pretty ruthless in applying a political lens to a lot of these decisions. When it comes to the safety net populations that I'm concerned with, there is much less partisan valence over it. And it's the conversation that takes place is much, it's not viewed through the lens of are we saving Obamacare? It's much more these governors want to be able to demonstrate that they're doing something effective, and they face these knotty administrative problems that require Medicaid to fix. So I think it's an easier, they don't have to confront the Trump administration to do the things that I'm talking about. And that creates a space for them that may not quite be there in the same way for these legal battles. I just don't know enough about that legal dimension. But I have not, I think it's different across different states, but I have not seen the face of these Republican governors that is in lockstep with, now I do think it is quite possible that some of them will be bought off as part of the legislative bargaining. But I do think they will be a force to temper this, and they're telling their senators, we don't like this. And one of the things about AHC is no one likes it. If you talk privately to people, they're like, yes, this is really crappy legislation. It's been unprofessional in its formulation. I keep joking to people that some staff member's girlfriend's phone number will accidentally be enacted into law because no one's proofread it. There's all of these things. That stuff kind of matters in the conversation.
But Harold, since I was trying to be optimistic before, I'm going to switch hats.
Oh no.
Just a little, and just ask, but don't you think that, it's badly written legislation, but the basic equation of getting rid of the financing, the tax on rich people and businesses, and needing to get the money for that from the one big pot, namely Medicaid, don't you think that's what's dictating both the policy and the internal politics? And so the question becomes in some ways how much this sort of nonpartisan side of politics, this Medicaid, can influence the politics that's playing out right now in the Senate. So, you started to say something about that, but I think you need to
Well, a couple reactions to that. One is, I mean, in some ways, the best bipartisan solution to this problem is, why don't you just cut all the rich people's taxes and leave everybody else's insurance alone? I mean, really, I don't want to cut taxes on the wealthy, but like, nobody's going to die because.
You can't do that with reconciliation.
If you can come up.
You can't.
You have the sunset, no?
No, well, yeah, but that's 10 years, hey. But you can't with the reconciliation instructions they adopted,
Right.
okay? But could you in principle do it in reconciliation? Yes, but in the 2018 reconciliation. Of course you could.
So I think if a way can be found for them to achieve their tax policy objectives while finding some way to put off these these painful Medicaid measures, I think they will be sorely tempted to be finding some pathway to do that, because they really do want to cut those taxes, so that would be. It is ironic to me in some ways that once again, deficit politics is generating even worse policy than if we didn't have deficit politics. But yeah.
I'm sorry, some other people have their hands.
Oh.
But one possibility is that they're driven to backload the Medicaid cuts because they don't want the political blowback.
And they never happen.
The hopeful scenario for you, Harold, is Democrats come back
Yes.
in 2018 and those cuts actually never get, never get into.
I think that is a very possible scenario. And I think that the incredible Republicans they were caught by surprise by the vehemence of the town hall reaction. And I mean, the Democrats really have begun to mobilize with genuine anger in a way that is scary to a lot of Republican political professionals. And now 2018, the Senate map, it doesn't matter as much for them. But that has taken something a step away from them. Yeah, Larry.
Everything you said about kind of an optimistic understanding of politics and the essential role that the Medicaid program plays on the ground, good works for people who are extraordinarily vulnerable. All that is very, very compelling. It feels, though, a bit one-sided because it's the side that's kind of the most optimistic. And, to kind of think of this in a balancing context, the side that we've been talking about all day is the dark side of everything you've just said. I can think of several senators who might well be sitting in these kind of nonpartisan conversations, or their staff are, and they're quite supportive. But the loudest voice they hear are people who will influence or determine whether they're renominated again, or whether they face the same outcome as someone like Robert Bennett or other kind of legendary figures who bucked their kind of Tea Party, libertarian, ultra-conservative base that now has a disproportionate, lopsided influence on nomination. So to me, it's not the absence. I totally agree with your presentation. It's more about how to balance that with this countervailing political force that literally has its hand on the neck of members of Congress and the Republican parties to whether their careers survive. Not because they're defeated in general election, because a lot of them are running in safe districts, but whether they're nominated again by their own party. And we've just seen this in the House. It's the driver of why the House passed repeal. And the question that I guess we get to is, in the Senate, even those that you kind of see as moderate, good people who are really concerned about policy, how do you situate them in this balancing context?
I think different people would be situated differently, and there's definitely groups of people that are exactly in the situation that you described. There's a couple of wild cards that I don't understand well. One is how President Trump's predicament factors into all of this, and their fears about the general election will shift if President Trump's support begins to appear like it's going to collapse in some places. That's not going to be true in West Texas.
But my question was about legislators. Could you give me one Republican legislator who is not potentially threatened
By a primary?
a hostile primary challenge?
Oh, I think people like Portman would be.
He's faced Tea Party challenges all along. And he
Yeah.
bucks the entire Congress on repeal. My bet is he'd face another one, maybe better organized and funded one.
Well, he might. But I think he's also.
He's got reelected.
It's the general election. I'm not talking about that.
He's got till 22.
There's two things about these guys. One is they're pretty secure, and so they don't have to be as worried personally. I mean, Portman, he's got a gay son. He's done a bunch of things that in some ways would raise some interesting inter-Republican Party issues for him. There's also this inchoate thing. When they start thinking about what are their grandchildren going to say, there's also an aspect there. And I do think that is, I mean, one of the things that was really striking, when I was involved in ACA, the day that the Democrats in the House voted on ACA, President Obama brought in there was a speech that he gave that many of you probably saw, where we spoke to the whole Democratic caucus, and he basically said, this is why we're here. And a lot of the people who took that vote actually pretty much knew they were going to lose. And I bet you a lot of those people now are telling their grandchildren, I was there in that room with President Obama. I served a term in the House, and then I became a lawyer in Tucson or whatever. But I was there when we did this thing. And, there was a largeness of the effort. And one thing that's lacking in the AHCA is any sense among the players of the largeness of the effort. And when you're this close, you're probably right that 42 of the senators, the Republicans, they just don't have to care about any of the stuff that I'm talking about. But there's a group of them that, from a mixture of personal issues, from a potential vulnerability to a Democratic challenger, to I just don't believe this is good policy, those are the people that I think are able to be swayed by this dynamic. And I also think even if this passes, I think that I'm also thinking what's going to be the next step after this. And I do think if they pass this thing, it's going to be a disaster, and there will be a different calculation. I'm sorry, I'm babbling. So, who had their hand up? I'm sorry.
So I've seen it doesn't work in U.S. politics. It sounds very interesting. I wonder if I could push you on something you said towards the end, which is when I think of kind of the institutional repeal of health policy globally, I often think of ideas preceding or leading to institutions. But towards the end, you said that, even if they're kind of thinking of the replacement, this idea that you need to have universal health insurance exists. So it's more like we replace it with something better. No one is saying we go back to a situation of a large number of uninsured people. And similarly, you spoke about the fact that even Republican senators have this sense of ownership over ACA. And so is there a way in which you're making an argument for how ACA, flawed as it is, has as an institution kind of created this kind of ideational support for the idea of universal? And so is that, to me, if there was this kind of like optimistic message, it was this flipping of an institution kind of almost creating both at even the popular level, this seeming consensus.
I think that's very well said, and I do think that that's what's happened. I think one of the problems that the Republicans had was that their most politically potent messages against ACA was that it didn't go far enough. Deductibles were too high. We gave you this insurance. We told you it would be great, and it's terrible. And if we come in, we can fix that and make it better with our free market, whatever. And of course, now they had no intention of actually doing anything to make people's insurance better. But I don't think they expected to be called on that. And by the way, if you say, why is the AHCA so shoddy as a legislative document? I think it's because they spent 7 years pushing a politically effective message that didn't line up with their actual policy vision. And they didn't do the work the Democrats did in 2006, 7, and 8, that a lot of people around this table were involved in, to line up the stakeholders to actually craft policy that you would want to pass, and that you could describe in a transparent way. When I look at say midlife Medicare, you can propose that, and you can start working on how it's going to work. You can campaign on it, in 2018 and 2020. And if you win, you can actually legislate the thing that you said. And you can say, we won, we have a mandate for this policy that we've been pushing for. If you're basically saying, I'm going to make insurance better than ACA, and you don't have actually anything in your briefcase to do that, you end up ratifying the premises behind the ACA to a great extent, at least in public opinion, to the extent that matters. There were some other people who, John didn't want to.
And this will be the last question. Go ahead, John.
Hey, a lot of pressure, John.
So
I'm sorry, that's not a good question. Someone else should have the last one. Go ahead.
I'm wondering if we'll consider a counter pessimistic hypothesis, which is that the bipartisanship in Medicaid politics is much weaker than we thought it was. I think you can argue the last 7 years suggest that when the Supreme Court ruled that the Medicaid expansion was optional, a lot of people said, look, the hospital associations in every state are going to fight for this, and the providers are going to want it, and all the states are going to do it. And I might be the only person in this room who lives in a state that hasn't expanded, but there are 19 states that haven't expanded. 18 of them are governed by Republicans, and while there has been much more so than the exchanges, because there's much more money at stake, significant Republican support for Medicaid expansion at the state level, the ferocity of the opposition in those 19 states, going out of their way to hurt state economies, state budgets, state hospitals, vulnerable people in the states, I think is a tell that bipartisanship on Medicaid might be more limited than we thought it was. And the fact that the House just voted to decimate Medicaid is another tell. Now, the politics in the Senate might be different, although at this point, what is standing in between Medicaid and hanging on here is the fact that Republicans only have 52 seats. If they had 57 seats in the Senate, we wouldn't even be, this conference would be even more of a funeral than it has been so far. I mean, so I hope you're right about the outcome of this, but I wonder if that bipartisanship for Medicaid is actually as strong
Well,
as you're suggesting.
I mean, this comes
Harold,
back.
before you answer that, can I ask a follow-up question to John? And that is, sitting there in North Carolina, which is sort of ground zero for ferocity, what explains the ferocity? I mean, at bottom, what is it that makes people so ferocious against the expansion? We've got about 6 theories that's floated through this morning, and I wonder what your take on it.
Well, I'm in Chapel Hill, not the real North Carolina, right? I'm not a good voice for this. I think, there's clarity to tell us there's been polling work done showing support for Medicaid expansion across the South and across the states that haven't expanded. So I think it has less to do with popular resistance than Republican, to Jacob's point, radicalized Republican conservative resistance to it. And anything, yeah, I think that's what it is in those states. But if we went back, we flipped it and sort of reversed time and went back to when the ACA was enacted, and we were coming off all the Medicaid expansions of the 80s and 90s. I'm not sure how many people would have predicted that so many states wouldn't have taken 100% financing for 3 years and eventually 90%.
Well, I mean, I'll give an answer which is partly optimistic and partly pessimistic. I mean, I do think that when I think about Jim's talk earlier, the racial politics of Medicaid have been fundamental. I mean, 90% of the human beings that are shut out of the Medicaid expansion are in the Old South. And it's exactly the same map that if you drew a map of which states did not take up Medicaid quickly in the late 1960s, it's exactly the same map. And I mean, there's lots of sheep in some other parts of the United States. If you look at a map, it doesn't quite look that way. But if you actually look at a map weighted by people, it is. And in fact, Colleen Grogan and Ethan Park had a J. Hipple paper where they showed that the public opinion among white people was very predictive of which states took up Medicaid, and public opinion among non-white people was not predictive. And it's the states where there's a Republican legislature and a lot of the perceived beneficiaries are black and brown, where it's been a heavy lift.
We need to stop there. Thank you so much, Harold.